Yeah. So questions or comments from the audience? Ramon, have we got any webcast comments?
No, I'll be passing along any webcast questions that appear on the monitor. We don't have any so far. Let's go ahead with the microphone over there, please.
Rick Satava, University of Washington. This is a very, very important session. I appreciate, Adrian, you taking the time effort to be putting this together. There's one thing I think that we didn't address, and I haven't seen it in the literature. We've looked at ergonomics, we've looked at burnout, but what we haven't looked at is the individual. We do not have in the healthcare profession, for surgeons and other physicians, an exercise program. We don't have a physical exercise program, and we don't have a mental exercise program. Why is it that, for example, not a single professional athlete would consider to belly up to the table? How many of your colleagues are standing away from the surgical table because physically their belly will not allow them to get into the proper position? Have we looked at the ergonomics and said, this is the areas that we see of stress, let's develop an exercise program for surgeons? Every single athlete that I know has a very rigorous, at least at the professional level, and I think the safety of my patient is every bit as important as winning a football or a basketball game. We've got exercise programs. Each member of the team has a different exercise program because they do different things. Has anyone ever looked at it? Why don't we have a surgeon athlete? Why are we surgeon donut and potato people? I don't know, but we are. You know, even myself, with daily exercises of a minimum of a half an hour to an hour, I still turn into a donut. And that's not good for my patients. The second is about burnout. And a lot of that has to do with expectations. You know, and I think some of the expectations are part of the times. So we are now expecting that, well, we shouldn't work as hard as we used to. And I don't want to be one of these old dinosaurs that says, well, when I was working, we did blah, blah, blah. But I think some of the expectations are significantly different now than what they were before. And in the military, we go to some very, very stressful situations, battle. There is a program that every soldier must take before they go. It's called Battle Mind. It's a very specific mental exercise program to develop resilience, the ability to continue to perform well under stress. These are available, as you said, in the ergonomics field as well, but we've never addressed them, but we just go ahead and say, well, it's not my fault. The bottom line is exactly what I think you summarized your table with in the last talk. You know, we need to look inward, see what the problems are, and work them, at least from our standpoint, as much as we need to go out and blame the system.
Those are great comments, Rick, and we'll wish you Godspeed with working on this donut problem. Don't give up. Great comments. Let me start with George. Let's speak to the issue of surgeon exercise or preparation for surgeries. Your group looked into this at all, and any comments in this regard?
We didn't look at the physical, which is important to look at. We didn't, but we look at the mental rehearsal before surgery, and there is positive effect of rehearsing and mental strength on task performance in the lab and in clinical work as well. I think there will be paper coming up very soon about mental rehearsing and effect on technical performance. And it also not affect technical performance, it affect only team communication, and this is objectively by measuring the team interaction. Having a mental rehearsal program, this will improve the outcome in terms of team communication. But physical we didn't study, although we having a competition between the patient who having oesophageectomy and the medical team, a half a marathon. So we'll see who's going to win, whether the surgeon or the patients.
Very good. I will say that I hope that we're able to report within a year or so with without lifting the proverbial skirt too high, this is exactly, you're setting the table for a study that we actually have underway, Rick, looking at the impact of not just pre, but intraoperative exercise and pausing, and looking at some objective, we're trying to establish some objective metrics. So without spilling the beans too much, this is a study we have underway because I believe very much in the importance of this topic. Question from this microphone?
Yeah, I wanted to talk about lack of trust and loss of control. You know, we impose a lot of this on ourselves with the American Board of Surgery. And when I come to this meeting and have to scan my badge and walk out between each meeting to get it rescanned to show that I'm here, is a lack of trust and a loss of control, and it contributes to surgeon burnout. And that's self-imposed by all of us.
Touche. Thank you for that comment. Question or comment?
Yeah, Julie Emmingen of Rochester, Minnesota. One of the out of the many important topics you've covered, one of the things I was looking at was the trocar placement that you talked about, and one of the things I find myself struggling with is the size of the abdominal wall relative to how tired my shoulders are, and it seemed to be dependent somewhat on the BMI of the patient, given the obesity epidemic that we're into and rolling into even more. Are there any thoughts about how to adjust things at the 10 centimeters to 10 centimeters and somewhere with a BMI of 24 and 44? Are there things that we should be looking at for that? Should we be using the robotics for a BMI over such and such? Are there any thoughts about any of those physical strains, although they're not the most important ones out of the whole area, but they certainly contribute?
Great question. Steve, do you want to speak to that?
This is certainly an area which has not been discussed adequately. But we do know a couple of things. First of all, the upper abdomen tends to be a little bit thinner, if you will, than the lower abdomen. The gut hangs down. But when it comes to the thick abdominal wall, we do know a lot about the force of putting in a trocar, and the angulation becomes more critical. So if you have a young, thin, or a pediatric patient, and you put the trocar in pointed exactly opposite where you want to go, it's pretty easy to flip that trocar around and to deal with that error. The thicker the abdominal wall, the more force, the more strain it puts on the surgeon in order to correct that. And so any misguided path through the abdominal wall becomes as critical as the thickness itself. So certainly an area that needs further study, but no, there's no guidelines at present for that.
Ramon, anything to add on that?
As the patient becomes thicker, obviously the relative position of the fulcrum point needs to stay the same, and so the table would have to go lower. This can be a real problem if you're in stirrups, you're using reverse Trendelenburg. So consider using some stands in those cases until we have better equipment.
Well, I'd just add to that, once again, the data is so sparse, and trying to make change without having kind of the baseline data has been one of the recurring difficulties in this field. I hope to get this out, and I'm not just speaking to the work we're doing, there's other groups doing, but we've actually not just tried to characterize our operative workplace, but our patient workplace. So we're characterizing abdominal wall thickness, mapping abdominal wall thickness, if you would, over a large series of patients. And so we hope to publish that this year. But it's a great question, and if we really can understand and can share the knowledge of what that topography is really like, that will help more objectively and scientifically think about trocar placement. So we owe you that paper too. Ramon?
A couple comments and questions. First of all, it's very exciting to see all the work that's happening. One of the problems with looking at ergonomic outcomes is that performance and workload do not track in a linear manner, and that is that the workload can increase substantially while maintaining performance, particularly for highly trained individuals. So what's exciting and difficult about this field is measuring workload, not just performance, and it's very exciting to see how that's coming along. I did have a few questions I'd throw out to the panel. Seating is a very important issue. One of the problems with seating is, what do you do with your legs? with the operating room table. We can't put our legs under current OR tables, so I would throw that out for the panel. How do we handle that issue? The camera holder, I think surgeons traditionally have loved to have human beings perform tasks that can easily be done by metallic devices, whether they're actuated or not. So I think I'd like to hear the panel's comments on the various camera holding devices. And then third, the question of hand size. Not all surgeons are the same size. Whether they're male or female, there are different hand shapes, hand sizes. Instruments tend to be one size fits all, particularly instruments like staplers. And so bringing in, should we vary the sizes of the instruments, or should we power our instruments? I'll just throw those questions out.
George, why don't you take a first step?
In terms of, I'm just answering the last one. In terms of the hands, practically speaking, sometimes it's very difficult to have more than one hand, change the hand of the instrument, depends on the hand of the surgeon, although it is important. But what we tend to do is try to, the way we hold the instrument, we told not to put our hands inside the rings. We tend to use the palm rather than the fingers. So we get over the problem of hands of the instrument by the way we handle the handle. This is what we tend to do. In terms of the camera devices can work when we have an easy operation which does not allow it to move quite a lot. But when we get a complex operation, sometimes the camera device doesn't work. And the reason for this is that control systems is not as good as the interaction between the assistant and the surgeons. But the camera device is part of the training opportunity for the residents as well. So one of the other things we need to think about is the surgeon, the trainee, will do the camera device as an intermediate step before doing the operation. In terms of the standing positions, personally tend to move my hands. Intends to as well use a foot step on the side to put my feet on. And tends in every, I do esophagectomy, gastrectomy, so long operations. Every couple of hours I take few minutes. And I know some of my colleagues as well take subcutaneous heparin injection for long minimal access operation.
You yourself do?
I do.
Wow. Interesting. Very interesting. Question. Oh, sorry.
Thank you. I appreciate that.
There's blinding lights here.
It's okay. Dr. Park, I think this was a superb seminar session, and I congratulate all of you for covering a topic that I think is critically important but very underlooked. A few years ago, I went to the internal people at my institution because I was having significant musculoskeletal problems and couldn't operate anymore. And they came to my work environment, went to my office, and gave me all the suggestions that you all put up on your pictures about where the monitor of my computer should be and where my chair height should be. And then they came to the OR and observed me for a couple of cases. And at the end of that time, he said to me, "Wow, this is a really non-ergonomic work environment, and I have no idea how to help you in here." So I think you've put together some very nice suggestions from the literature about what can be done to help in our work environment in the OR. And I have two questions about kind of disseminating that information out. One is, did you all at the University of Maryland go to your internal people who look at work environment, ergonomics, OSHA, to give them that information to help your surgeons at your institution? And is that something we ought to be doing across the country? And the second is, do you know if SAGES is doing anything about putting those kind of guidelines together that Steve put together for his talk here?
Thank you. Great comments and great questions. The second one first. At this point, it hasn't been, but as Steve's presenting, and I just sat through a very long board and exec meeting, I'm thinking, okay, next guidelines project. One of the issues is again how paltry, as we keep coming back to how paltry this data is, and I hope for the surgeons in the audience who are thinking of looking for ideas to spark research projects or bodies of work you can get engaged in, I hope you're hearing that there's a world of opportunity, and this is going to be on a lot of people's radar screen. in the next couple of years. It has to be, and we're kind of sounding this clarion call to more and more folks who, as I said earlier on, did not realize they're stakeholders in this issue, and that's part of what we have to do is educate folks. This is not just a parochial surgical problem. This is going to affect the delivery of care. To your first question, at Maryland, actually, we started this work. I was at the University of Kentucky where we started this work. And a little story I like to tell is that I got together with the group you're alluding to, you're asking about. We had an ergonomics group, and they kind of both did research and tried to make recommendations. And so this was probably 15 years ago now, or 10 or 15 years ago. And I knew early on, if I was going to do this, I could tell, I've done minimally invasive surgery for many, many years, and I knew that this was going to take a toll and potentially shorten my, career versus if I'd done all open surgery. And so got with this group, and we set up a complete intraoperative real case study, motion analysis, force plate, the whole thing, and had them evaluate me, do a lap chole. Well, it's a very comfortable operation, and it takes 15 to 20 minutes, and they did all this thing and went away and did their analysis. And as I've told the story before, I thought they were going to come back and say, well, that was poetry in motion. It was beautiful to behold. And in fact, they came back and said, if you were a small business, we'd shut you down. And I thought, that's a lap chole. You haven't watched me, flail through a tough colon or any of these other things that we do. So it put in stark kind of context and contrast for me where we are versus 23 pages in poultry handling and guidelines, really?
Really?
So, here we are doing this vitally important work with so little to guide us. And so the point you raise, the questions you ask are so important, and we just have to start raising awareness, increasing this knowledge base to establish this understanding of a matrix of surgical movement, upon which then we can make objective recommendations. And we're just so far behind the 8 ball in this regard. But this is absolutely what we could do. The questions you're asking are just so important. Any other comments?
Yeah.
Sure. It's a difficult problem, and it can sometimes fall on deaf ears. If you pop into another surgeon's operating room and you see them in some awkward contortion, and you try to point this out, they say, I just got to get this bleeder. It'll just take a second. This one is worth it. And that's a tough attitude to beat. And when you try to follow that up with, yeah, but that's really unsustainable postural instability. You push up your glasses. They call you a funny name and kick you out. And it really is an important point that is not well known, and it is something that we have to have more sessions like this, maybe some guidelines, and some more concrete data to make the recommendations so that we can clear this up and make it something that's accepted.
I think the organization, the institute, and the SAGES to play a role, this is pretty crucial. And the EAS, there will be a manual, has been already written on the ergonomic aspects, taking into account port location, imaging, table height, everything together, which will be on the website soon. So I think having SAGES to having a leading role, this will help other institutions and other hospitals to work on. I think it's a duty of the organization, I think.
I know, it's a very good point. Ramon, are we going to add something to that?
No.
Okay. Is that Matt?
Yeah. Matt Shane from Lexington, Kentucky. Comment and a question. First of all, I really appreciate Steve's work on the ergonomics. I can't stress enough in my own experience, just using really a platform setup of almost like a stage on one side. I mean, I'm 6'2", but the table can always go up, but you can't go down any lower. I never have a problem getting the table up to any height you need. So even for taller surgeons, most of the time open cases, I've never used a step up ever, unless I was operating with my boss, C. Dan Smith, in which case I think I'd use 2 or 3. But that can really help, and really it doesn't take very much money. Most of the time the step-ups are already available in the operating rooms. It doesn't require any physical input from you at all, just getting the operating room staff used to putting about 6 or 8 of them on one side of the table for you to operate makes a world of difference, gets your arms in better positioning. As far as a question, this is more of a general question, and I hate, anytime you bring up surgeon burnout, you always run the risk of turning this into a big complaint session. But I think fundamentally what we're dealing with is that as a profession, I think we're being pulled in 2 separate directions. and both for probably noble goals, but on the one hand, we're getting pulled to try and reduce our work hours, improve ergonomics, other things to make the job that we do easier and make us better at doing them. But at the same time, we're confronted by the fact, as you rightly pointed out, that our numbers are dwindling, the expectations for work are increasing, and the reimbursement for that work is also decreasing. So we're being pulled in two diametrically opposite opinions or directions. And perhaps an additional factor of burnout is that those of us who are looking to be in this for the next 20 to 30 years are seeing the fact that many of our political leaders have all these great plans, but ultimately the role of carrying these plans out falls upon our shoulders, and we're being pulled in these two separate directions. And I don't know which organization or how, as a group, we need to stand up and say, well, look, we need to prioritize here and figure out what works best and come to a common solution, because otherwise it's going to be decided for us.
These are great comments. I'll ask Ramon to give a response to that, and I'll say as well, you know, we're, as a group, we tend to be very goal-oriented, very, you know, decision-making oriented, and I think getting this in our radar screen first is a legitimate thing. This isn't whining. This isn't, you know, showing weakness or vulnerability. This is an issue central to our kind of professional survival. So raising awareness among us is the first thing, and then raising it among, as I say, other stakeholders in the entire healthcare industry is our next important step. We do very well at being kind of organized and scientific and methodical. We're that way in our work, and we have to be that way with this as well. We have to generate the data to support the arguments. Ramon?
Stephen wanted to make a comment about the
Sure.
table.
Just about the table, what came up earlier is that what do we do with our feet with a table with a center post? There's really kind of no place to put them, or how many steps do we stand on because the table doesn't go low enough? Maybe this is a table problem. Most kitchens that I've been in the world have tables like this with legs at the corners, not in the center. Our current OR tables are very sophisticated, but perhaps designed for a different purpose, for open surgery. So having powered legs, having a suspended table, having a shelf that juts from the wall are just a couple of possibilities that we really need to challenge our assumptions and think about what it is we're trying to do and how we can best accomplish it. So I applaud your countermeasures, and maybe we need to discuss this at a manufacturing level.
And until somebody falls off the superstructure of step-ups that we, it's what we need to do. I will also point out that there's a new system, comes from Portland, I believe. Its initial focus is going to be on pelvic surgery, where the surgeon is actually suspended over the patient. I don't know how many of you have seen this, but it's a seat that essentially rides over the patient. The patient's draped underneath it, and you're kind of suspended in a position oriented to do pelvic surgery more comfortably.
Like a hang glider, Dr. Park?
It's a little bit undignified when you first see it. I will say that. Anyway, do we have any more questions?
Yes,
One
sir.
more comment.
Hi, Liz Robertson. I'm one of the chief residents at Washington University in St. Louis. And for the past several years, you know, I've had the room set up for the attending and watched how they've done it. And my question is for Dr. Kavik, as I go into practice, if you could set up my operating room for me, you know, you'd get me a gel pad and you'd put my arms at the right place. But, you know, we don't have a lot of data, but I wanted to know what you would tell me to do for my operating room step by step.
Boy, that's an easy one in 30 seconds or less. But it is difficult because it depends on a lot of factors. What procedures are you going to be doing? And what exactly is the institutional constraints of what you're dealing with? So we cannot eliminate all of the ergonomic risk factors of surgery. It is a physical process. It is an intimate contact sport, and you're going to be there, that's involved, and you're going to be doing things that are ergonomically unfavorable no matter what you do. But you need to have something with boom-mounted screens that come down, and you need to position yourself and use the most appropriate instruments that you can find in order to do your procedures. But I'll be happy to chat with you later if you like.
Thanks.
And I think to add to that too is this concept that Rick raised about preparation in terms of physical preparation, and then I think we're going to be looking in the future to having set pauses and set maneuvers that we do through the course of an operation to kind of refresh us. Anyway, I want to thank the panelists very much, and good questions and comments from the audience, and we'll close this session. Thank you very much.